All right, so scenario one, this is just a case that I made myself based on things that I'd seen both in GP and hospital. So again, as a candidate, you would have had 5 minutes to prepare for this case. So the timer would be set, and this is the scenario. So a 60-year-old Indigenous male, Daryl, type 2 diabetic, presents with numbness and tingling to his right foot. He has been non-compliant with treatment for his diabetes. And then we can see that there's 3 questions again. There's 4 minutes for the first question, 4 minutes for the second question, and 2 minutes for the final question. So with regards to what I'd be thinking of, I want to consider, you know, I definitely want to have a culturally sensitive approach to this. I'd be considering using an ALO if he's an Indigenous male, and I'd want to get an adequate and thorough history. So thinking of any previous medical conditions, what his previous medications are, has he had any surgeries, what are his allergies, and throwing in your SNAP, your smoking, nutrition, alcohol, physical education is quite good. With regards to his diabetes, I want to know what his blood sugar levels are and what kind of things are limiting his compliance. Is it that he doesn't really understand what diabetes is, or he just has seen people not take their medications, and he is in 2 frames of mind if he wants to be compliant or not, and you know, has he had the education from potentially a diabetes educator, and then doing a focused examination, taking into consideration the differentials that I'd be thinking of. So could it be a diabetic foot ulcer, a DVT? Is it peripheral neuropathy? Could it be trauma or sciatica? But keeping it quite broad. So doing a focused cardiovascular assessment, checking his BP, doing a diabetic foot assessment, and inspecting his foot, checking for pulses, seeing if there's any cuts or ulcers, any deformity, anything that he's not noticed, any skin or color changes, and consider doing a Doppler, which you would be able to do either in your rooms at the GP or at the hospital if that's where you were. Considering the investigations for this gentleman, so I'd be looking at doing diabetic cycle of care bloods and urine for your microalbuminuria, and considering a formal ultrasound of his lower legs. With regards to management, so he would need adequate control of his diabetes and doing a chronic disease management plan for him to be hopefully able to see the diabetes educator, the podiatrist and dietitian would be helpful. Involving the ALO or the Aboriginal Liaison Officer and the diabetic educator in the consultation would be quite helpful. Getting the pharmacist involved to give them a bit more information about the medications, the benefit of using them, and getting their family and support person involved as well, discussing any problems with regards to what may happen if there's long-term non-compliance, such as amputation and dialysis. And they've probably seen a few people in their own community that may have required to do that. So that might be something that will prompt him to hopefully be a bit more compliant. And so the second question for this particular scenario, so you see Daryl at the hospital 2 months later, and he is presented via QAS feeling nauseous and diaphoretic. A nurse has done an ECG, which you can see below, and describe your management. And this particular case has 4 minutes. So sometimes the images that they give you, either the ECG or if it's a fracture, it may not be super clear if it's just on a laminated piece of paper, and they do sometimes have it on an iPad. So if you are struggling with it, you might want to ask if there's something clearer that you can see. So with regards to this one, so your overall statement for this is he's an unwell patient with the possibility of deterioration. I'd like him in the resus bay with full monitoring and defib pads on. And also quite important to have consideration for the rest of your department. If it's quite a busy ED at the moment, I'd be thinking of safely discharging patients if I could. And if I had the foresight of actually knowing that this patient's coming in by QAS, I might be able to organise my department a little bit better. Calling in for extra help is advisable, and calling in my radiologist. I would also call the Aboriginal liaison officer and any family if I have the patient's chart, or if I have access to details for family members, I would do that. And then I would like to take a systematic doctor's ABCDE approach to this patient. So looking for any danger, checking for patient's response. I've already sent for help, and then assessing the patient's airway. Is it patent? Is he talking? How is his breathing? Is it laboured? You know, just talking through those ABCDEs. So for his circulation, I'd like to get a current set of vital signs. So I'll check his blood pressure, his heart rate. I'll check his central cap refill. I would like to place 2 large IV cannulas. One of the other doctors who I've asked to come and assist me can assist with that. And I would like to take some bloods off for an ISTAT. So I do a VBG and a Chem8, and I'll send off some formal bloods as well, which I appreciate I will not have the results for, given that I'm in StAMPSville. I would like to give aspirin 300 milligrams if he's not already had it by QAS. I'd be giving clopidogrel if there's no contraindication, looking at giving enoxaparin subcutaneously and IV as per the guideline based on his weight. If he's got any chest pain, he can have some oxygen, giving him some analgesia with regards to fentanyl IV, and keeping him constantly monitored. I'd be doing another ECG and seeing with regards to what are there any changes, and do I have any changes that are dynamic in relation to the ECG that I currently have. I mean, on that particular one, it's hard to say exactly how many millimeters of ST elevation there is in V1 to 4, but the one that they give you will be blown up a bit more, so you'll be able to see that a little better. And then talking to my referral hospital, my tertiary hospital, yeah, talking to the cardiologist there and discussing lysis if there's no contraindication. They might also then ask you, okay, so what are the contraindications to lysing this patient? And you can throw in there that, you know, if you've lysed the patient, you want to see an improvement of 50% within the first 60 minutes after giving that. And obviously doing serial ECGs is important to be able to keep track of that, making sure that the patient is, yeah, comfortable, and consideration for a GTN infusion if they've got ongoing pain and they're not hypotensive. Discussing this patient with retrievals early would be advisable as well. So, and then the next question, Daryl returns to see you one day, stating his daughter is due to give birth next month. Discuss your recommendations. So this is the one with regards to the flexibility in your answers. So it's sort of slightly changed track on the question. So I'd be looking at talking about a pertussis booster if he's not had one in the past 10 years as per the immunisation guidelines. And I would recommend that he has this one 2 weeks prior to being exposed to the little bub. I'd also discuss with Daryl about the influenza vaccine, and that he can have that on the same day, he can have it in a different arm, and with regards to his chronic disease management, he should probably have the influenza vaccine yearly. And keeping himself in good health would be important, just with regards to just long-term recommendations for himself as well, compliance with his diabetes management, and definitely his medications post-STEMI as well. So if he's had any medication changes when he went to the tertiary hospital, and finding out, I guess, with regards to follow-up with regards to his cardiology appointment, if he's got that via telehealth or video conference, or does he need to potentially go in person, and also considering a T health assessment in this patient would be helpful. So, and the next couple of slides, essentially, they're just the answers that I had for that case. So I just noticed, so in the questions it says, will they say if patient is Indigenous? If not stated, do we assume patient non-Indigenous? So they usually will specify. ACRIM is really good in specifying if the patient is Indigenous or not. But if they've not specified it, I would still say I would like to be culturally appropriate in my questioning of the patient. I would offer an Aboriginal liaison officer. But yeah, usually ACRIM will tell you if they're Indigenous or not, but it might be good just to throw that in into your answer.